Let's start with a little saying, because I think this kind of exemplifies what the era of hepatitis C is all about. There are things that we know about. There are things that we know that we don't know about. But what is really worrying is that there are things that we don't know about that we don't know about. And this is what Donald Rumsfeld said. And I have to say, I'm not a great American fan, but it is probably about the wisest words he's ever said. So let's put this back into context, and I know that you've spent a lot of this morning thinking about the epidemiology and the global issues with hepatitis C. As you can see from the global deaths report in 2010, liver disease is continuing to increase year on year, and that the contribution from hepatitis C is continuing to increase year on year. So this is not an insignificant problem. Hepatitis C is a global problem, and I know we're here today and tomorrow to talk about Central and Eastern Europe, but as you can see, there are other areas of the world where hepatitis C is a big problem, but certainly here, it's an even bigger problem. Hepatitis C is not a single genotype, as you know, and there is a different distribution of genotypes across the world. And so genotypes still matter, and that the treatment that we need to think about in terms of the DAA era needs to be genotype focused, at least at the moment. That will change in years to come. So, just some very basics. SVR12 is sustained virological response, which is cure. SVR is certainly associated with a reduction in liver-related morbidity and mortality, reduction in overall mortality, and an improvement in quality of life. This there is no doubt about, so this is data we've seen already. And that we know that there's a possibility that if you get an SVR, you will reduce transmission in vulnerable populations, and this is something that we need to learn about, apart from modeling data. And we certainly need to think very much hard about whether SVR equals reduction in non-liver related morbidity and mortality, and this is something that we'll need to gather data on as years to come. So let's go back to the basics. What are DAAs? As you can see, so this is the genome of hepatitis C. It encodes for a number of different non-structural proteins that are broken up from a single polyprotein, and these become targets for specific drugs that inhibit them. So you can see there are NS3 protease inhibitors. These are all labeled Previrs, and there's a number of these that are already licensed and a few more that are coming through. You've got the NS5A replication complex inhibitors. These are probably the single most powerful agents against hepatitis C in terms of picomolar concentrations and great activity against hepatitis C. And there's at least 3 of those licensed, coupled more to come through. So these are all called ASVIRs. And then finally, you have the polymerase inhibitors, the NS5B inhibitors, of which there are 2 classes. There's the nucleosides and the non-nucleosides, very much like the HIV nukes and non-nukes. And again, as you can see, there's a number of these already licensed and a number coming through. These are all called Buvirs. Okay, so that's the nomenclature for the DAAs. So we've seen an evolving landscape of hepatitis C treatment. In 2010, 2011, we had telaprevir and boceprevir that came along, and this was a real game changer for hepatitis C. So for the first time in genotype 1 patients, we moved from SVR rates that were between 40 to 50% down to 65 to 70%. So a game changer in terms of treating people with genotype 1 hepatitis C. As you can see, there's a number of agents that have come through since then, and now in 2015, we're talking about interferon-free DAA-based therapy. As you can see, there's a few of those licensed already, and we'll talk about these in detail. So these are the currently licensed DAAs. As you can see, the protease inhibitors, telaprevir and boceprevir, are now becoming redundant, and so they have seen their days. They were game changers, but they are now too toxic to be considered first-line therapy. You've got cimeprevir, parataprevir, which is ritonavir boosted, and then asunaprevir, which is licensed in Japan, but not the rest of the world. In terms of NS5A inhibitors, you've got 3. You've got daclatasvir, ledipasvir, and ombitasvir, and then you've got sofosbuvir and dasabuvir as NS5B inhibitors. Okay, so just to your relief, I'm not going to show you lots and lots of data and try and show you loads and loads of graphs. Yes, we will have some of those, but you don't need to know and synthesize all this data. The treatment guidelines do it for you. We've got some people who are part of the EASL treatment guidelines here who've sat for hours synthesizing all of this data, and they've come up with these recommendations that they've put into nice little tables. That's what you need to go and do. You need to go and look at these tables because these are absolutely phenomenal. So they're freely available from the EASL website and published in the Journal of Hepatology, and they've divided these into non-cirrhotic and cirrhotic, and then given you a choice of different drugs. So PEG interferon ribavirin with sofosbuvir and cimeprevir, and these are the only interferon-based regimens that EASL now recommends, and then the rest is interferon-free. Okay, so what am I going to do for you over the next 20 minutes? What I thought we should do is look at some pertinent issues that I think need further discussion, and this is where we should look at some of those wonderful bar graphs that all go over 90%. So I thought there were 3 things, or maybe 4 things that we should think about. What is the difference between genotype 1A and 1B, and what drugs need to be different for 1A and 1B? When do we need ribavirin, and what's the optimum duration of therapy, and who might need longer therapy? For genotype 3, this has become the new problem genotype, and we'll talk about that in a little bit more detail. What are the optimum treatments for genotype 3? I'll give you a summary of the treatment options for 2, 4, 5, and 6, and then a little bit about renal failure, because I think this is an increasingly difficult population that we also need to think about. Okay. So just so that I wouldn't leave the Americans out, these are the AASLD, IDSA, IAS guidance, very similar to the EASL guidance, but I've highlighted this because this is a nice graph to put up, and this is where you try and see where you need to think about prolonged therapy and where you need to think about adding in ribavirin. If I get this to work, okay, doesn't matter. But as you can see up there, that where I've highlighted the reds is where this is cirrhosis, and that's where you probably need longer therapy, and that's probably where you would need to add in ribavirin as well. And so what I'm going to try and show you is some specific data. Fantastic. So cirrhosis, prolonged therapy, or the need for ribavirin, and that's the specific data that we probably need to look at in a little bit more detail. So this is the really lovely phase 3 program for sofosbuvir and lenacapavir. These are the ION studies, ION 1, ION 2, and ION 3 in treatment-naive and treatment-experienced patients, looking at 24 weeks of therapy, 12 weeks of therapy, and then for treatment-naive patients down to 8 weeks of therapy with or without ribavirin. And as you can see across the board in ION 1, ION 2, and ION 3, over 90% sustained virological responses with or without ribavirin. And so we were beginning to see some great responses, but we were also starting to see some issues in terms of those patients who were treatment experienced and probably had cirrhotics. And the numbers were small here, but we were starting to see perhaps things not quite creeping over 95%. And so when you look at this in a little bit more detail, this is ION 2, this is Harvoni plus or minus ribavirin, 12 or 24 weeks. And as you can see, in those patients that were cirrhotic, we were starting to see issues around 12 weeks of therapy unless you added ribavirin, and then 24 weeks of therapy plus or minus ribavirin didn't actually make a difference. You then go back and look at some pooled data and the impact of treatment duration and ribavirin in cirrhotic patients enrolled across a number of different sofosbuvir and lenacapavir studies. Then you can see that in treatment-experienced patients, as you add ribavirin or increase treatment length to 24 weeks, you're starting to get better responses. But if you did just sofosbuvir and lenacapavir alone, then the sustained virological response was somewhat lower in that those patients had a higher risk of relapse. We also found that those patients who had platelet counts less than 75 were the more difficult to treat patients. So certainly with this regimen, with cirrhotic patients, we need to think about adding ribavirin for 12 weeks, or if they're ribavirin intolerant, extending out to 24 weeks. So what's the difference between genotype 1A and 1B? And you all know this, but the biggest difference between 1A and 1B is the propensity for protease inhibitor mutations. As you can see, 1B requires 4-step changes to get mutations to protease inhibitors. 1A requires 2-step changes. So wherever you have a regimen that includes a protease inhibitor, then 1B will respond a lot better than 1A. And this isn't true for sofosbuvir ledipasvir because it doesn't contain a protease inhibitor. And so let's go look at some of the data from the pooled studies with the genotype 1A patients from AbbVie. This is Sapphire 1, 2, Pearl 4, and Turquoise 2. About 25% of these patients had cirrhosis with genotype 1A infection, and this looked at ribavirin or placebo, and it looked at patients with cirrhosis and without cirrhosis. And again, as you can see up here, that the addition of ribavirin, certainly in those patients who had cirrhosis, made a huge difference, and that ribavirin was really clearly very important for this regimen. In genotype 1A patients, sorry, this was without cirrhosis, so genotype 1A. And then with cirrhosis, it was not only the addition of ribavirin, but extending therapy out to 24 weeks that made the difference. So again, with a protease inhibitor regimen where genotype 1A and 1B differ, you need the ribavirin, and you probably need to prolong therapy out to 24 weeks for those patients that are cirrhotic and difficult to treat. This is the impact of treatment duration, and this is comparing genotype 1A and 1B. And as you can see with 1B, 12 weeks with ribavirin was absolutely fine, even in the most difficult to treat people, but that this became an issue in those null responders with cirrhosis where you really did need to prolong treatment out to 24 weeks. In the real world, where we use protease inhibitors, this is HCV-TARGET using sofosbuvir plus cimeprevir, which is a protease inhibitor. You can see the differences between 1A and 1B. 1A tend to have a lot less responses than 1B because now we have a protease inhibitor in the mix. The same applies to Unity 2, which is daclatasvir, asunaprevir, and baclobavir. This is the BMS triple combination. And again, you can start to see issues with treatment-experienced genotype 1A patients. So the take-home messages there were treatment for genotype 1A infection with an NS5A and a 5B combination, addition of ribavirin for 12 weeks in cirrhotic patients. If ribavirin not tolerated, contraindicated, extend therapy to 24 weeks. And then some patients, even within that subgroup, may benefit from extension to 24 weeks with ribavirin, example, in patients with platelet counts less than 75. With the PI, NS5A and 5B, this is the AbbVie 3D, or SIM-SOF, ribavirin is probably required for genotype 1A patients, for genotype 1B with cirrhosis, and will need extended therapy to 24 weeks with ribavirin for genotype 1A cirrhotic patients. So we are starting to see the differences. So let's go on to genotype 3. Why is genotype 3 a problem? And then we started to see some of this quite early on in the evolution of hepatitis C treatment. This is some really nice data from the VA study, which it looked at patients with genotypes 1, 2, and 3 who had attained a sustained virological response or not attained a sustained virological response, and then looked at mortality in terms of overall and liver-related mortality. As you can see, with genotype 3, the slope was much steeper than with the other genotypes. So we began to realize there was a genotype differences in terms of morbidity and mortality. We also started to see with the valence and fission studies, this was SOF ribavirin or PEG ribavirin, that those patients with cirrhosis tended to respond less well, especially if they were treatment experienced with sofosbuvir and ribavirin for 24 weeks. So we were already starting to see issues appear with genotype 3. If you look at the activity of the current DAAs against genotype 3, the first thing to note is the PIs have no activity against genotype 3. Sofosbuvir has great activity. Dasabuvir has no activity, it's genotype 1 specific, and then the NS5A inhibitors have some activity, but they're not brilliant against genotype 3, and even amongst those, there's a difference where we think daclatasvir is probably better than ledipasvir in terms of its activity against genotype 3 virus. So ledipasvir, sofosbuvir, Harvoni is not licensed for genotype 3 patients, but this is some data from small studies looking at treatment for 12 weeks and SVR12, and as you can see, cirrhotic patients don't tend to do very well, and then they fall well below the 90% that we're now expecting of all our DAA-based therapies. If you look at ALI-3, this was a study looking at SOF and daclitaxel for 12 weeks in patients with genotype 3 hepatitis C infection. They had small numbers with cirrhosis in this phase 3 trial, but again, we begin to see that there was issues with cirrhotic patients, whether they were treatment naive or treatment experienced, if you gave them 12 weeks for genotype 3. You could see this in much bigger real-life cohorts. So this is the NHS England EAP, or the Expanded Access Program, which treated about 500 odd patients, and this was reported at EASL recently. And this is SOF-DAC and SOF-DAC ribavirin for 12 weeks, and as you can see, at best, we were getting 70% sustained virological responses in this group of patients. Similar sorts of things were noted in the French compassionate use program. This is an interim analysis of SOF-DAC plus ribavirin, but this time patients got 24 weeks of therapy rather than 12 weeks of therapy. And you were starting to see in cirrhotic patients better responses as you extend out to 24 weeks. So again, clues that a difficult to treat group of patients, extension of therapy may be very useful. The study that's probably really clearly defined what we need to do for this group of patients is the BOSON study, which compared SOF-RIBA for 16, SOF-RIBA for 24 weeks, and SOF-PEG and RIBA for 12 weeks in English genotype 3 hepatitis C mono-infected patients. And I think the bottom line is to look at this group here, cirrhosis, treatment experienced, almost 90%, if you give them 12 weeks with SOF, PEG, and RIBA. And so this is the one time where we think PEG and RIBA still has a role to play in treatment of hepatitis C. So the take-home messages for genotype 3 infection are SOF, PEG, and RIBA for 12 may be the best current option in treatment-experienced patients with cirrhosis. For DAC and SOF, addition of ribavirin and extending to 24 weeks may be required for advanced cirrhosis patients. And to achieve high SVR rates with SOF in genotype 3, an additional active drug other than the currently available NS5As may be required. And there's a number of drugs coming through with very good activity against genotype 3 virus. So this is a summary of all the other genotypes. Genotype 2 is pretty much the easiest to treat. 12 weeks of SOF and RIBA, 16 weeks with cirrhosis and prior null response, and genotype 2 is done and sorted. Genotype 4 behaves very much like genotype 1, although data with this is quite scant, but all the treatment regimens are very similar to genotype 1, and there's some more data to come this year at the AASLD meeting. Genotype 5 and 6 are rare. The only thing to note is the first generation PIs are not active against genotype 5 and 6, and so the current recommendations are either Harvoni or daclitaxel and sofosbuvir, or even PEG interferon ribavirin and sofosbuvir. So I'm going to end with a final thought, and this is talking about patients with renal impairment. Why is this such an issue? Because renal impairment is common in certain subgroups of hepatitis C infection, especially intravenous drug-using populations. They have traditionally poor responses to PEG interferon and ribavirin, vastly because ribavirin is poorly tolerated in patients with renal failure. Anemia is rate limiting, and then some DAAs are renally cleared. Sofosbuvir metabolites accumulate in patients with an eGFR less than 30. So a number of studies are now starting to come through looking at how we manage this population. This is the RUBY-1 study, which is EBV-3D, which is a small pilot study looking at patients with CKD 4 and 5 renal disease with either 3D or 3D and ribavirin if they had genotype 1A, and no ribavirin if they didn't have, if they had genotype 1B. These are some early responses, as you can see, for almost all the patients had reached out to the different phases. They had become aviremic, and certainly 2 patients had reached SVR12 by the time RUBY-1 was reported. The other group of drugs, which are not quite licensed as yet, but we think will be licensed before the year is out, is grazoprevir and elbasvir. And this is 12 weeks in treatment-naive and treatment-experienced genotype 1 patients with CKD. 12 weeks of therapy, I won't go into the details of this, but sustained virological response 12 of over 90% and approaching 95%. So I'm going to end by saying the future is very, very bright for all our patients, but we must have a look at the future with our binoculars open, because there are issues and problems that we will need to deal with in terms of hepatitis C. So I'm going to conclude by saying interferon-free DAA therapy is possible for almost all patients now, and there are pertinent issues with new emerging difficult-to-treat groups, especially people with advanced cirrhosis, prior null responders, failures with DAAs, and patients with renal failure. Ribavirin use in extending therapy is certainly an option at this stage, but we will need new drugs as we go into that. Drug-drug interactions will need to be overcome, and I say next lecture, but I now need to say last lecture because I was late. And what I haven't discussed today, and perhaps we could have a discussion if people want to, is the impact of baseline resistant associated variants and treatment emergent mutations. And then certainly something that we need to think about is how do we roll out treatment? Who do we prioritize for treatment in the next couple of years? How do we engage people in care? And perhaps the ultimate goal is to find, test, and treat so that we can have elimination of hepatitis C in our lifetimes. Thank you very much.